I was once told that my child would, quote, never be fat. But lo and behold, this skinny child of mine is downright pudgy, with fat thighs and a belly for the first time in her life. She's now in her late 30s. I admit she doesn't get much exercise except for aquatics in the summertime. She can't walk long distances. Or is she just gaining weight as we all do later in life?
Yeah, I mean, we are seeing this in our young adults. I would say that it's ironic with the struggles that we have with the infants and young children, but I think it's part of just the natural, like you said, weight gain that happens in most of us, or in many people as we get older, and the effects of whatever it was that was causing the failure to thrive in infancy and childhood are not there anymore. And so it's ironic that we do talk about, sometimes we even have a dietitian see these young adults for talking about healthy eating habits and nutrition and exercise and activity when 10 years earlier they were seeing the same patient for helping them grow and gain weight. So we have been seeing that.
I think also because the height tends to be smaller, that as people are putting on weight as they age, they don't have as much height to balance that out. And so I think I have seen this in my older patients as well, that that you don't have as much space to put that weight in because the overall height is less.
The other thing is, we get older, we tend to put on weight. Let's just admit it, We don't get the exercise we have when we're younger, and I think that adds to it as well. So this person probably, without exercise, that's probably contributing to the weight gain as well.
I know, just speaking for myself, there are metabolism issues that come into play as you get older. I know that I have a favorite patient at home, and he and I walk at least 5 miles a day, and he's been gaining weight pretty significantly over the last few years. Medication might have something to do with that. All right, question number 3. Autism is certainly on the rise. Do you have any theories? I know there is an autism center in Baltimore. Didn't they once check for SLOS in their blood bank and find that many had SLOS and not just autism, which I understand is just an umbrella term for, quote, we can't explain why your child is like this, end quote, question mark.
Break that down, if I can remember all of it. Let me do the blood bank thing first. So we did a study. Denny has been part of that, and we continue to look. And we looked at individuals who had autism. We didn't detect SLO in this group, but we did find low cholesterol in 20% of the individuals. We've expanded the study a few times to larger groups, and so that's one component of the question. So there wasn't a lot of SLO, but there is something else that's causing low cholesterol. We don't know. We're in the middle of we're looking at some. Denny and I are working with a statistical geneticist trying to find the gene and trying to get more samples and kind of go down that path. So that's one thing. So increase in autism. So autism is about 1 in 31 individuals in the U.S. A lot of people, it's being diagnosed more. People vary in what they think. A lot of people think it's more that it's being diagnosed rather than actually on the increase. It may be a bit of both. We've had lots of developmental disabilities over the years. Autism, and they change the criteria every couple of years. It's really messy because we don't have a diagnostic blood test like SLO, right? So, and you can get more services if you have the diagnosis for autism, so that drives it as well. And I think there was a third component to that.
I think
that you covered both.
Addressed it.
Okay.
Oh, just this idea of to what extent is autism an umbrella term for we can't explain why your child is acting the way it is?
Somewhat true, I guess. So I'll address. So I think the term umbrella term is right on. So essentially, and most of our psychiatry disorders as well, because we don't have diagnostic blood tests. We don't have a blood test or an x-ray that you can do to say you have this disorder, like an SLO. Like SLO, before they discovered the cause of SLO, it was you had to have a certain amount of physical difficulty, physical features or differences. But once they realized that, oh, no, this is actually what it is, all of a sudden individuals could have just a little bit of toe syndactyly, toe webbing, and you have it if you have the blood test. So in psychiatry, including autism, we don't have like one diagnostic blood test, or at least for, let's say, like depression. So in autism, it is an umbrella term for behavior, you're right. There's lots of, we know at least probably 200 genetic disorders that present with autism. Autism is a behavioral diagnosis. It's saying you have these features of social and language, and sometimes you have repetitive or certain behaviors. So it's a descriptive diagnosis. It's not one disorder. We know at least 200 genetic disorders, and eventually when everybody gets exome sequenced or genome sequenced.
Yeah. Do you want to answer?
Yeah, I think that it is true. Autism, there are certain diagnostic criteria for autism, but autism can either be a single condition, its own disorder, or it can be seen as a symptom of other disorders. So there's autism sort of, that's the only problem the child has, or there's autism as part of an underlying genetic condition, like Smith-Lemli-Opitz syndrome, like tuberous sclerosis, like some other conditions. I can tell you that in our clinic at Children's, and Amy, keep me honest here, it's the most common referring diagnosis. And that's because our genetic testing has finally gotten to the point where we're doing exome analysis and now genome analysis, and we're able to increase that number of underlying genetic disorders higher and higher. I haven't seen anyone diagnosed yet with Smith-Lemli-Opitz syndrome that presented as autism. What we're seeing now is an increase in a new group of genes. And it's basically, I call them the name of gene in quotes, hyphen neurodevelopmental disorder. They're all genes that people have known existed. They're either genes that function in neurologic development or help other genes work, but have not been associated with human conditions before. So we're finally starting to, the diagnostic rate is increasing there. So I think the autism story is being written from an etiological standpoint, but there's a lot more to come to that, and it's really being written on the basis of improved testing.
Vaccines do not cause autism. I need to say that very strongly, and I'm going to talk about that a little bit more this afternoon. So I'm both a geneticist and I'm boarded in a subset of neurology called neurodevelopmental disabilities. So what I've been doing for the past 45 years is assessing children with developmental disabilities and autism. And we have such incredible advances in our ability to find underlying genetic causes for autism. We can send a simple blood test and find genes that cause genetic disorders. And on these panels, there are many genes, far more than 200. Let's try adding a 0 to that and another digit, 2,000 to 3,000 genes on certain of these panels where if autism is your diagnosis, you would send that panel. And now we can do these broader panels, whole exome sequencing, whole genome sequencing, and look at the entire DNA molecule and find these incredible genes, many of which we just don't know a whole lot about. Interestingly, insurance companies now, private, those of you with, whatever it is, United Healthcare, Anthem, whatever, if autism is a diagnosis, they will actually pay for the testing now because those tests are now recommended for people with an autism diagnosis. So that actually buys you your insurance being willing to pay for that test these days.
Just to add my sort of evolution of genetics pitch here, the testing we have now is phenomenal. I mean, we have never seen diagnostic rates like 40 to 50% before. I mean, Dr. Elias and I sort of trained in the days of, having less than 10%, 2 to 3%. So having something, but that still means that there is 50% out there that our current genetic testing isn't able to identify. And I do think we are at this pivotal time in genetics and genomics where we're beginning to move from just diagnostic testing to gene-informed therapy. And that's the reason for actually identifying the underlying genetic defects for some disorders, because at some point there may actually be a genetic therapy or a gene therapy. And I don't think it's that far away. I think we're looking 5 to 10 years, which sounds like a lot. I mean, you probably all watched the Today Show a few weeks ago when the group at Penn and Chop talked about the gene therapy for the metabolic condition. I think that, it's a big deal to do something like that, but all of the geneticists up here have actually seen things that are big deals that are now being done a lot. So it's important. It's an important time in genetics. It's an really important time to advocate for funding for genetics research, for funding for newborn screening, for funding for vaccines, because all of the work that led to this time was done in places like the NIH and academic medical centers on the basis of funded research. So we really are at a different time now, and it's great to be here.
I was just going to add that, the testing has gotten so good. So when something doesn't seem like it fits, testing is a really good way to look if there's a second condition. And I have done exome on a child who was presumed to have Smith-Lemli-Opitz because things didn't add up to me, and found a second diagnosis. So I think if you ever are in a situation where there does seem to be other medical problems that are coming up that don't seem to make sense or don't seem to fit with what is known, testing can be a really good way to make sure that you've looked for other genetic conditions.
Thank you for that. Although there's another question about testing from Zoom chat, I thought we'd also hear from some folks who are in the room.
To further this questioning, we were tested 16 and a half years ago for SLOS. Would it be wise for us to pursue further genetic testing to see if there's anything else there that we need to be made aware of?
So I think part of that depends on what is going on for your child and how much Smith-Lemli-Opitz diagnosis encapsulates what is going on for your child. And so I think when we've thought about children whose features don't quite fit or whose growth doesn't fit or have other medical issues that would be well outside the spectrum of what is going on, then I think yes. I think if you really feel like, and your clinicians feel like this is the diagnosis, and you've got the biochemical testing and you've got the genetic testing, and everything feels like you have all the pieces to the puzzle, then there is always the chance, the other flip side of testing is that there's always the chance we find something we don't know what to do with. And so genetic testing isn't black and white like checking your platelet count or something. And so we often get results that are uncertain. And so if you now have uncertain results in other genes that may or may not be relevant, that obviously can cause a lot of challenges. And so I always like to have a good reason for a specific symptom I'm going after, because there's always that chance I find something I can't explain.
Yeah, that's a problem we run into because I come at it from the research perspective, and we're interested in building databases so we can understand the variability in Smith-Lemli-Opitz syndrome. So we're asking a different question than a clinical question. But we end up turning up things that we don't know what they are because it is research.
Add a friendly amendment to Dr. Kritzer. I think that if the question is it going to make a difference now versus could it make a difference in the future, I think I tend to look at what do you need to know to sort of be prepared for the future. If we're looking at gene therapy in the future, knowing the specific genetic variants that people have, I mean, that's what's going to be targeted. So you may not get any information now to help with that therapy, but if you look at, for example, if you take cystic fibrosis, which there are hundreds and hundreds of variants out there, the beginning genetic therapy was really targeted at a specific group of patients that had a specific change in their genes. So it's good information to have.
I was just going to add one other thing about genetic testing is that it can be very important in terms of recurrent risk in your families. If you have other children who someday will be having babies, and there might be something that runs in the family that has a risk of recurring in future children. It's important to understand that because there's good prenatal testing these days. There are more interventions and treatments available for various kinds of conditions. So knowledge is power, and understanding the diagnosis in a more updated way can often be very helpful for families.
While we are talking about testing, I'll remind everyone that Natera is conducting a study to develop and validate a non-invasive prenatal genetic screening test. And they're a sponsor of this conference, and they and Travere would love it if you'd stop by and chat with them about some of these topics, and also thank them for sponsoring. Thanks.
I have a couple questions. First one, how far away are we for diagnostic blood tests for autism? That's the first one.
So I think there is no one cause for autism. So I think that's the issue. The best testing now, and I'll defer to Dr. Tierney, is really the neurodevelopmental behavioral testing. But autism, as you've heard, is really caused by, in the thousands of conditions right now. So you have to kind of know it would be the diagnostic test for whatever that condition is.
Which is the genome sequence. Go ahead.
Which actually the genome sequencing is going to get you the farthest right now, but that's still looking at about a 40 to 50%, somewhere, 30 to 50, depending on whose study you look at, because there's still, even with genomic testing, there are parts of the genome that we just can't look at yet. But it is getting better. Some of the labs that now do genomic sequencing, exomes and genomes, what I usually tell patients is this is an evolving story. And the way exomes and genomes are interpreted are they actually, even if you look at an exome, which is the 30,000 protein coding genes, they don't look at all 30,000 of those genes. They actually, the way they do their algorithms is they look for the genes that have been associated with a condition, okay? And a genome is even more expansive. So many of the labs that are offering this testing offer a free reanalysis in 2 to 3 years because they know that this information is evolving. And so what they'll do is they'll take the sequence and they'll add the new information that's come up. So it is an evolving story. Some people get their answer on the first shot, and others it's negative, but that doesn't mean something isn't there. And that's where, geneticists and developmental physicians tend to follow kids. Come back in a year, come back in another year, we may have more to tell you.
Now, if you have a disorder that's already is known to be associated with autism, like SLO, then the diagnosis, there is no blood test, it's a descriptive diagnosis by saying, what is the language function, what is the communication function? And then you can have autism with or without the behaviors is how it's conceptualized presently.
So my daughter was diagnosed probably about 10 years ago doing the West test, and that's how they found that she has Smith-Lemli-Opitz. So do you think I should ask them to update it and to do another, or I mean, she's got the dual diagnosis of autism too, but do you think it would be worth it? Because what you had just mentioned about the updates.
I don't think so, unless, you know, as you mentioned, there's some other medical cause. I think we know that at least 1/4 of individuals with SLO have autism. It depends on, you know, which procedures and how it's. We previously said about 50%, and now they changed the diagnostic criteria. It's all artificial. They sit around a table and say, well, we're going to call this, you know, you have to have this many criteria. So I think if they have SLO and they have these kind of features of autism, it makes sense. We see that a lot. Even if you don't have, even in individuals who might not meet the full criteria for autism, they definitely have the autism traits.
And then gene therapy, you said it would be available in the next 5 to 10 years, approximately. How will it affect our families with SLOS?
I think gene therapy is coming. Gene therapy, gene editing, you know, essentially curing conditions is happening today with other conditions. There's a handful where gene therapy, gene editing is really revolutionizing the therapies for these other conditions. So it's only a matter of time. We have heard recently about a group that is developing gene therapy specifically for SLOS. I'm particularly optimistic about gene therapy for SLOS, even in older individuals, because I think a big part of the learning disabilities and intellectual disability is related to myelination. And myelination occurs even certainly into the 20s and sometimes maybe even into the 30s. And so I think we could make a significant difference in the lives of patients, even with gene therapy given in young adults, and perhaps even in older adults. It might impact behavior and so forth. So I'm very optimistic about gene therapy. It's a little bit harder for gene therapy for conditions that affect the brain. But again, there are exceptions to that. There are gene therapies for conditions affecting the nervous system.
And could we also be reminded what myelination is?
Go ahead.
So myelination is the formation of white matter in your brain. And the brain in humans is not fully myelinated at birth, right? You know, we're not like, you know, other animals that can be born and go running down the pasture, right? There are a lot of connections neurologically that happen in your nervous system after birth. And this process of sort of coding the nerve cells, the neurons, so that they can talk to each other is a progression that happens a lot during early childhood, but then there's some continuing progression later. There are also problems in patients with Smith-Lemli-Opitz that can be progressive over time. You know, I've been looking at retinal function and hearing function, and you know, there can be many different organ systems that can show changes and progressive disease over time in a patient with Smith-Lemli-Opitz. So those things one could, you know, sort of intervene more readily and prevent further disease progression. What you can't really do are birth defects. You know, those are caused by problems that happen very early on in pregnancy. So doing gene therapy in an older child is not going to reverse the problems that are anatomic.
We've worked together for a really long time, so we're really good. You could probably tell just who answers what.
We worked on this together since the 1980s.
Yeah. So the one thing I would say is that, you know, there are a lot of benefits to being in an advocacy, a foundation, fellowship foundation, a parents group. And this is actually one of those benefits, because quite often when new therapies become available, when new researchers are trying to answer a question, the first thing they will do is contact the condition foundation. Because they want to get the information to the families. And I've told families for any condition that I follow is if you hear something, you are more likely to hear it first than I am, because it takes a while for papers to get published. And so that's another reason to remain members of a foundation like this great one, is that when new things happen, it'll probably come through the foundation.
We just answered Carolyn Kelly's question in chat, which is great. We will soon get to Alicia's, but first there's another one here in the room.
You partially answered a question I had, which is about we may see the changes in neurological in children, but it can't change like the organs that didn't grow because they didn't have cholesterol. So I was just wondering if you think there is a gene therapy that would happen for carriers before they get pregnant. Okay, so you shook your head.
No, I think that's really challenging, and you might think, can we do this prenatally in the developing embryo or fetus? And there are a lot of sort of restrictions on that, because there's a lot of fear you could introduce something that would change the child.
Just to piggyback on that, I agree with that, and I think there are, if families know they are carriers of a condition, there is technology using IVF for screening embryos, and at this point that is the option that we have for screening embryos and choosing embryos that do not contain the same genetic variants. And that is an option that some families choose and have had good success with. Yes, it is very expensive. It is not covered by all insurances. That's amazing. It is and most of the public health plans don't cover it in the United States, but some of the private ones do.
There's a question over here on the other side of the room as we hear from Dr. Tierney.
I do want to, in my talk, I'm going to address psychiatric medications that increase 7-DHC. That is important, and I'm going to discuss how if an individual is a carrier, such as the mother is going to have a child or might possibly become pregnant, so they're a carrier, they have the trait, they're one of the genes that's known to, that would cause SLO if you had 2 copies of it, like from the man and the father and the mother. If the mother is a carrier and the individual, if she takes a medicine that increases 7-DHC, the embryo is going to be more affected physically, whether or not that embryo has the trait or not, even a typically developing individual.
Hi. I have a question over here, a couple questions. One was just out of curiosity for Dr. Elias. Why did you use soy oil instead of other oils for the suspension?
That was a really good question. Soy oil is not the only oil that I've used, because there are some patients who are allergic to soy and cannot take that preparation. So I've used other kinds of oils instead. And why did we choose oil versus, say, an aqueous suspension? It looked at studies that were done, 30 plus years ago. It looked like the absorption of the cholesterol would be better if it was in an oil-based suspension versus an aqueous suspension. So that's why we picked it, and we're trying to go for what would be the least expensive that families might have to pay for, and soil was very easily available, that's why.
We were really fortunate enough when this first all came to be, both being at Tufts, and Tufts University has a nutrition school, the Francis Stern Nutrition School, that's internationally renowned, and we literally walked down the hall and met with a sterile, nutritionist and talked about how cholesterol can be absorbed, and what we heard was has to be in oil. You're more likely to absorb it in oil. And then I think we said, well, which oil? And so, he said, just use soy. because it's the most, it's available, and unless you're allergic from it, it works. I actually had a patient, I use soy for most of my patients. I had one patient on grapeseed oil because of allergies.
And I don't know if you've heard this story, but I was having Thanksgiving dinner with a cousin of mine who happened to be a senior person at a pharmaceutical company that made pharmaceutical grade cholesterol powder. Because I was saying, how the heck am I gonna find cholesterol that I can give to these patients whose cholesterol levels are so low? And my cousin said, oh, this is easy, man. My company makes this. And so it was kind of serendipitously wonderful that we were able to pull those things together.
Thank you. And I have one more question for Dr. Rizzo. Regarding photosensitivity, is it common to have like eye sensitivity to the sun but not skin? Or is there some correlation or differences with that?
I imagine you can have eye sensitivity to the sun too. That's like photophobia, okay, where you don't like the bright light, so you squint and so on. That can be seen in a number of conditions, and it can be, I suppose it could be a problem with SLOS patients, but I have not heard a lot about that. Have you?
Yeah, I'll take that one. So I've looked at this extensively, particularly involving the retina. So you do want to protect the back of the eye, the retina. You want to protect it from sun because there is accumulation of 7-dehydrocholesterol all over your body, but in the retina, if there's sun exposure, those chemicals will be converted into chemicals, oxysterols, that are even more toxic to the retina and can cause the retina to really become sick. And so, yes, wearing sunglasses that are protective against UV light is very important for the eyes. And I have seen patients who do develop, red eyes and sensitive eyes, and it can be painful to be exposed to increased light.
Before we go to another question here in the room, we have a question from Colombia that is connected to the first question just asked. Hello from Colombia. We would like to know if the cholesterol made by Dr. Elias is available to be purchased as a regular supplement.
So what we do, we used to be able to make it in the pharmacy that was near where I lived and practiced. So when I was here in Massachusetts for a long time, there was a pharmacy here that compounded it and shipped it all over the place. And then I moved to Colorado 24 and a half years ago, and I have a pharmacy there that does that. But then insurance rules changed. And now they're not able to ship it to other states because other state insurances will not cover it. So what we've been doing is providing the recipe. And so people's local pharmacies can purchase the raw ingredients, and then a compounding pharmacy can make it and dispense it locally for patients. That's what we've had to do so that local insurance companies in whichever state or country you live in can pay for it there.
Great, thank you for that answer.
Mine's in the same vein. So Cholextra, which you're familiar with, I'm looking at the ingredients, and it's missing that oil piece. It's not. It has oleic acid, so I wasn't sure what was like how.
Yeah, you don't need the oil. It's the cholesterol we're trying to get in, but you can't just give it as a powder very easily. So that's why we turned it into a suspension, a liquid form. That we can put it in the G tube. We can give it by mouth. But the oil is not.
That's a powder, right?
The
Sorry,
oil.
this is the powder. I get my question
It's
is.
the powder that you want to get in. Yeah.
But my question is, should I be taking this and putting it in oil for absorption? If this is.
Yeah.
No.
Right.
No, it should be designed to be well absorbed. There's probably a proprietary formulation that we don't know about.
Okay.
It's encapsulated. You don't want to put that in oil. It hasn't been tested that way.
You were saying that you could get this to our pharmacies. How would you go about doing that? Would it have to be through our pediatricians, or could you just call it into the pharmacy for the child?
Yeah. It would have to be a local doctor who is prescribing this to get your insurance to cover it. But we're happy to supply the recipe, to people, to any pharmacies anywhere who would like to make it.
So what would we tell our pediatrician we're trying to get? Would it have a certain name, or?
Well, it's a cholesterol suspension that it was specifically designed for a patient with Smith-Lemli-Opitz.
You'd have the pediatrician contact us, like Dr. Elias.
I just have a question. So my son, his levels are not increasing at all. They're like just under 60. And so I'm just wondering, because we've had a problem in the past where, I don't know if anyone else did, but he has to have it through the G-tube, and it was clogging like a wooden artery, and it was like making the little tube really hard, and food, you would try to pass through food as much as you could, but they only give you 4 a month, and no matter how many I bought, so they came up with putting it in the food itself, mixing it up, and then but I'm wondering if you think if it's diluting it and it's not being absorbed readily, or if he just needs a higher dose, or if it's some sort of absorption, or what we think.
What form are you using?
The liquid, we go to Acton Pharmacy, which is not covered by insurance, but.
In oil? It's an oil.
It's in oil, yes.
So I think it probably is best to mix it with the formula first.
Okay, yeah.
I don't think you're losing significant amounts that way.
Okay.
If it really isn't working, I guess you could try something else. You could try egg yolk. You can put egg yolk into the formula.
Do you want
Okay.
What kind of G-tube is the question?
It's a Mickey button. Okay.
People have good secrets.
Yeah. Okay.
The other thing that you've heard a lot about, Colbam, here at this conference, and for people who have pretty low cholesterol levels, their bodies might not be making enough bile acids in the intestines to help them be able to absorb the cholesterol you're giving. And so I have used Colbam, which is a bile acid, to help increase the cholesterol level for people who, just get into that stuck place that Dr. Irons was mentioning earlier, where you can't get the cholesterol level up higher, and you're not going to absorb more depending on how the intestines are working. So.
I think the other thing to think about, and I think this is what your doctor does when you're at a visit, is sometimes especially if kids are growing, the cholesterol is being used. So just having a level that isn't rising may not be a bad thing if your child's growing. If your child's growing and is healthy, maybe that works. Maybe if you figured out the dose, that kind of works. But I wouldn't go chasing levels without having that clinical interpretation of is it working? The two of them are sort of done together.
Good questions. We have another one in chat connected to this. Sonic cholesterol made from lamb's wool fat. Is that okay for kids with SLO? Any research on absorption on sonic cholesterol?
Yeah, that's right. Do you guys know about it? Yeah. Yeah.
Cholesterol is cholesterol, guys. Yes. Okay. These are just various ways of trying to get it into a form that's more easily administered to your child. The oil suspension. Richard Kelly invented an aqueous suspension that we used historically. Dr. Steiner went with egg yolks. there are umpteen ways. Cholesterol is cholesterol, and while I'm on egg yolks, cholesterol in raw egg yolks is the same as cholesterol in cooked egg yolks. Don't go giving your child a disease that you don't want because we're spending lots of money on raw egg yolks.
And eggs are very expensive these days.
Yeah. So I believe the sonic cholesterol is just another one of these encapsulated forms like we talked about earlier.
And, you know, I think, you know, to everyone's point here, I think from the very beginning, we went with cholesterol and suspension because it was the most effective and efficient way of giving large doses of cholesterol. The Oregon group always went with egg yolk because it is the best absorbed. You know, if you look at how much cholesterol is absorbed. But for some of the kids with the really severe cholesterol deficiency, you'd be eating like 10 eggs a day. And so it just became difficult. And so the suspension, we used the suspension, the Oregon group used the egg yolk, you know, and then Dr. Kelly developed an aqueous suspension that some people are using. So whatever works is fine, as long as, you know, you're working with a doctor that knows about the condition and that can, you know, check levels.
Excellent. I see some other questions in the room, but I don't want to ignore this one from Alicia in Ottawa. Thank you for joining us remotely, Alicia. She asks, is there any progress on getting SLOS on the newborn screen in the United States? I recognize that a simple blood test for cholesterol won't diagnose, but it would be an indicator, ? I'm looking into this in Canada, so any additional information would be helpful.
I think all of us are probably supportive of developing newborn screening for SLOS. I think that's a great idea. In the United States, in the past, we've had a committee that helped guide development of newborn screening. Newborn screening is a state-by-state issue, but the states are looking to the federal government for guidance. Unfortunately, that committee was dissolved earlier this year for no apparent reason. Okay, this is one of the committees that wasn't congressionally mandated, and so the administration could just dissolve it. So that committee's been dissolved. We can talk more about that later if we want to get political. That committee had some sort of some guidelines as far as whether they would recommend addition of a condition to the newborn screening panel. And a couple of those guidelines included there had to be a treatment and there had to be a test. Currently, I think there's an argument about whether or not there's a treatment for SLOS. I think the committee would probably say no. That's my personal opinion. So that's a challenge. Secondly, there's not a good biochemical or sort of biomarker test for SLOS that's high throughput, that's easily done. One could do genetic testing, but there's no real precedent for that today in terms of statewide newborn screening programs, but that technology is improving, and that sort of genomic or genetic testing is being done in research studies and will be done in the future. So this is going to become easier. And labs like mine are trying to develop a high throughput biochemical test for newborn screening for Smith-Lemli-Opitz syndrome. So that's a long way of saying keep watching this. I think there's going to be changes in how we do newborn screening. There's a research program that's going to be coming, probably approved this summer, to look at genomic newborn screening, where you can screen for hundreds of tests at the same, hundreds of conditions at the same time, and that will undoubtedly, shouldn't say undoubtedly, it will likely include SLOS. Mira.
Yeah, I think that ditto everything Dr. Steiner said. I think that if you look at newborn screening in the United States, I mean, we're a federalist society, so the newborn screening programs reside in states. And if you look back, I always think history, kind of understanding the evolution is important. You know, before this committee, that the advisory committee was formed, what your child was screened for depended on the state they were born in. So there were states like Massachusetts that screened for, back then, maybe 40 or so conditions, and then there were states that screened for 5 or 6 or 7 conditions, which was just inherently unfair. And so the American College of Medical Genetics convened an expert panel to go through this whole list of genetic conditions to determine, which should be on a uniform screening panel. And were you on that committee? Yeah, Dr. Steiner was on that committee. And then that committee actually was brought into the CDC as an advisory committee, and something called the RUSP, or the Recommended Uniform Screening Panel, was formed. And so there were recommendations to the states. These are the conditions that an expert advisory panel said should be screened. And we're in this time period where the committee's been dissolved for now. Newborn screening is still happening. I mean, states are still doing newborn screening programs, and we'll see there's a lot of concerned people that are trying to come up with a plan B for the time being. But, I say all of this because advocacy is really important. Legislators in states, these are state programs. And so legislatures in states listen to families, listen to people that have conditions. And newborn screening is probably, to my mind, the most important public health program that this country has had going back to the 60s, when states did PKU and hypothyroidism. As Dr. Steiner says, it's shifting now. There have been 5, 6, large research studies looking at genomic newborn screening, which will shift the paradigm. Instead of going like condition by condition, there will be hundreds of conditions that are screened for. And I think that we're preparing for that. There was just a National Academy of Medicine report that was put out on that. So things will be changing, but advocating for them is really, really important.
Thank you for those answers. Here's another question in the room.
So we've heard a lot in terms of the negative effect of 7 and 8 DHC in children with SLO. And I think yesterday there was some discussion on the value of vitamin E in helping reduce overall 7-DHC. And I also heard anecdotally maybe CoQ10. Is there any other nutritional support that we can be using in terms of supplements and/or nutrition to help decrease that and at the same time improve cholesterol intake, absence of colbam for the time being?
So your liver is where cholesterol is made, and the liver has a feedback mechanism. So if the cholesterol level in your body is too low, your liver will try to make more. But if you have a block at that final step of making cholesterol in your body because you have Smith-Lemli-Opitz, then the liver only succeeds in making more and more of the 7 and 8 dehydrocholesterol because it's not able to turn that into cholesterol itself. So one of the reasons for thinking about giving cholesterol and raising the level of cholesterol is to try to calm the liver down and say, stop working so hard and stop making so much precursor. The second thing that we've learned in the past 30 plus years is what happens to that precursor as it builds up in the body, the 7-dehydrocholesterol, and it just converts back and forth from 7 to 8 dehydrocholesterol. So usually I look at both of those. And Dr. Irons mentioned the sterol ratio. So in people who don't have Smith-Lemli-Opitz, all of your cholesterol is cholesterol. But if you have Smith-Lemli-Opitz, part of your cholesterol, it can be a very high ratio, is actually the precursors instead, right? It's the 7 and the 8, which don't work like cholesterol. They don't do the same things you need cholesterol for. So we know it doesn't work like cholesterol. The other thing we understand now from the work of Lieben's group, he's in Seattle, is that those precursors get oxidized into these very toxic compounds called oxysterols. And these oxysterols can damage various organs and parts of the body. They damage the retina, they damage the brain cells, they can damage your skin and contribute to the photosensitivity. They're everywhere, those precursors, and the oxysterols too. So how do you prevent the 7-dehydrocholesterol from being oxidized into these toxic oxysterol compounds? Well, you can try to block sunlight, the UVA light. You can wear protective clothing. You can use sunscreen and protect from skin exposure. You can wear sunglasses. But also certain vitamins are called antioxidants. And there's a wonderful SLO researcher in an animal model named Steve Fleisler. Dr. Fleisler has done a lot of work looking at the vision pathway and the hearing pathway in an animal model of Smith-Lemli-Opitz, and has showed that if you give antioxidants to those animals, that you can reverse some of the toxic effects of oxysterols. And so that's the vitamin E may be the best vitamin that works. E as an elephant. But there are other vitamins with antioxidant properties. And in Colorado, I use a substance called Decus Plus, which has a lot of different antioxidants in it, about a half dozen of them, and that's what I'm using with my antioxidant research protocol, and I'm following retinal function in the patients on that protocol. So, from what I've seen in my patients, COVID made it really hard for patients to travel to Colorado for a long time. There is some benefit to antioxidant use in reducing the oxysterol levels and the toxic effects on retinal function. So it's something that needs more research, more confirmation. And, but I think that going forward, you can't stop the production of the precursors if you have SLO, but maybe you can prevent the accumulation into more toxic substances. Does that make sense? Yeah.
Next question. I spoke to some of you individually. I just would love to get some feedback from all of you, if you wouldn't mind. My sister is 56 years old. It's been about 30 years since she's been doing anything specifically for SLO. It was about 30 years ago that she was on cholesterol, and then she came off of it. Since it's been so long, my question is, would you recommend getting another reevaluation and possibly going back on it? And also, what would you think about getting her a G-tube now at 56? We continue to have difficulty getting her to eat, and I'm thinking that that could be a solution to ensure that she's getting the calories and the nutrients in her. Any thoughts would be lovely.
I mean, I don't know what her nutritional status is. If her, uh-huh. Right. For quality of life reasons, so that you don't have to fight with every meal, a G-tube is a relatively straightforward and an easy procedure to do. Would allow you to give sort of baseline nutrition stuff and let her eat for pleasure whatever she wants. It's also a way to get medications in without fighting. So for quality of life reasons, and those are very, very important, it might be something that I would consider. I have patients who are adult age like that who seem to benefit from being on cholesterol, and so in my mind at this point, for your sister, you just want her to live as life that's as happy and comfortable as possible.
You might have a hard time, though, convincing an adult gastroenterologist to do the procedure if your sister is normally, if she has normal weight and good nutrition.
She's not normal weight. She's very low weight.
She's very low weight. Okay, that's a different story then. And I think it's a good idea to get back, if she hasn't seen a geneticist who's knowledgeable about SLOS in 30 years, I think it's always a good idea to be connected to a specialist.
I would just echo that the G-tube really becomes like an insurance policy and allows her to eat for fun. And then you have the G-tube if you need it for nutrition. I've also think that, if you feel like things are going in a direction where she's going to need it, it's almost better to do it sooner when she's healthier than to be in a situation where hydration is now a struggle and other things. And I'm a big fan of just being able to eat what people want to eat, and then anything else. You also have a lot more options through a G-tube for if volume becomes an issue, for using things that are more calorically dense. And I think, in thinking about quality of life, it does take the pressure off of having to eat and drink everything by mouth. And I'll also echo that I think it is absolutely, if she hasn't been seen in a long time, could be an opportunity to get back into care. And just in terms of thinking about someone to advocate for her with other subspecialists in terms of what is Smith-Lemli-Opitz syndrome and what isn't, because I think the issues where we talk about other conditions becomes more of a concern as people get older and people start having what I affectionately call older people problems that are going to kind of hit everybody, is making sure that people aren't ignoring other health issues for her because she has a diagnosis of SLOS.
I know that yesterday I spoke with Dr. Tierney about Mackenzie and his meds, and you said that Zoloft was one of the ones that increases the 7-DHC. I was wondering if we could get a list of meds and their substitutions, and if there's a way to reverse the damage done from those meds.
Okay, so yes, so in the handout I include a list of the medications. In the last two slides of the handout. I have to say there isn't a lot of research done on these medications. So if someone is not yet on a medication and a doctor wants to say, well, which one should I go on? Then you choose the one that's we think less likely to increase the 7-DHC. If someone is on a medication already and appears to be doing well on it, then it's going to be kind of the doctor to do risk-benefit. Do we try switching off? Because probably a lot of these medicines, the benefit of the medicine is going to outweigh maybe any increase of 7-DHC. So so it would be a discussion. And also when looking at the list, I've made a list of kind of the ones that probably are the first choice. That's only going to be one consideration that the doctor will do in addition to what are the other potential side effects. Are we trying to hit 3 different disorders like obsessive compulsive plus ADHD? Now regarding reversing adverse effects of 7-DHC.
So it sounds like, are you concerned that you may have done damage by using the medication in the past, or?
Diarrhea, and I don't know if it's just like a GI thing or if I'm just not certain. He's had diarrhea since January. Yeah. And the only thing the GI can tell me is give him more fiber. But then there's a fine line between giving him more fiber and having him constipated or having him have diarrhea. So there's no in between. He either has diarrhea or he's constipated.
And he's been on sertraline a long time though, right?
Yes. So it's not necessarily the med that I'm concerned with,
sertraline,
but I just don't know if there are side effects to being on meds that will increase the 7-DHC.
So I think over an abundance of caution and to be theoretically pure, we don't want to give anything that will increase the 7-DHC, but we certainly haven't proven that it's bad to give medications that increase 7-DHC. It's just, we're just being overly cautious. You have to use what works at the end of the day, what is best for the child. And if there's something that works equally well and doesn't raise the 7-DHC, then that's what we would recommend. But in terms of the diarrhea, yeah, I would agree. It sounds like maybe there's something else going on. That's, you know, do you have a geneticist or metabolic specialist in addition to GI?
Hi, Dr. Kritzer.
So that's good. So I think your doctors will work together and try to investigate what else might be causing the diarrhea. Because if there's a medication that the child's been on for a long time, it's unlikely that that's a cause of something that's more recent.
Great. We have time for just 2 more questions, both here in the room.
You all were saying that they need vitamins. What vitamins do they need to be on, and what is the life expectancy of SLO?
So we've looked at life expectancy of our cohort, and I think the easiest way to express it is 75% of the individuals, 3/4 of the individuals were alive at 35. Have to jog my memory as what on my figure. So I would not express it as what vitamins they need. I think it is experimental, and there are hypotheses where antioxidants, specifically vitamin E, may be of benefit.
For the life expectancy, I just want to clarify that that's just because we didn't have a ton of individuals who are older than that we could include in our cohort.
You know, so I have patients in their 50s and 60s, you know, they don't have major birth defects. They're sort of fairly healthy and stable overall. Patients with more severe disease, and that can be anything, not just SLO, but if there's a child who is in a wheelchair and is not ambulatory, who might have seizures, who can't really handle their secretions very well, and are at risk for developing pneumonia, those patients have a shorter life expectancy because they can get sick, they can have a respiratory illness that they're not able to manage, and can have a shortened life expectancy because of those other issues.
Hi, I have just a very quick 2-part question and then a comment and one extra question. The foundation lists your contact information in our brochure for everyone on the Medical and Scientific Advisory Board. How comfortable should families be to reach out if they have further questions, they or their physicians? The second part of that question is, now and then our kids are in crisis, and we have kind of developed a way for us to be able to send you information regarding that family. How comfortable are you all still to be contacted by a physician, by a family? Do you want to speak to, if that's still a direct line, or if you prefer that to go through a physician?
So I get emails, phone calls from everywhere, every week. and I'm perfectly comfortable managing those as best as I can.
Okay.
From families and physicians? From both. I get messages from physicians, I get messages from families. Sometimes it's easier to deal directly with the physician because they can make things happen. They can order labs, they can order referrals to various specialists and things like that might help the patient more directly.
Yeah, you can always reach out to us. I just ask parents also include a protocol coordinator or staff clinician who's helping to run the protocol so the email doesn't get lost. And if you don't get a response, just email again. I would underscore it is often helpful you can reach out directly yourself, but if you can get your physician to reach out too, because we're at a distance, and it's just easier sometimes to get the information we need from the physician to get you the best answer. Otherwise, sometimes I'm stuck in just saying, well, you got to go to an emergency room and have the physician call me when you get there, because I just need somebody to lay eyes on your child to know exactly what we're dealing with.
I'll save my other question, and I just wanted to make a comment that the Medical and Scientific Advisory Board offers, and all of our speakers offer their time at no cost, no honorarium. It's an incredibly generous thing that you have provided for our foundation for years and years and years and years. And so I want to offer a very warm thank you. If you guys would help me to thank the board.